So the ASPEN trial is a study of patients with Waldenström's macroglobulinemia. Patients were required to have a WHO diagnosis of Waldenström's, to have an indication for treatment. And for those who have not experienced other therapies in the past, they must have been considered to be unsuitable for standard chemoimmunotherapy. So in total, around 18% of patients were frontline patients and 82% of patients had previously treated disease. Some of these patients, most of these patients would have been MYD88 positive because most Waldenström's are MYD88 positive. And those patients were randomized on a one-to-one basis to receive treatment with either Ibrutinib or Zanubrutinib. About 10% of patients who were MYD88 negative were enrolled in a third arm where they get Zanubrutinib without randomization. And the ASCO report, it regards the randomized portion of the trial. This is Ibrutinib versus Zanubrutinib in MYD88 positive Waldenström's patients. Well, the study was set up as a superiority study to try and prove that Zanubrutinib achieves a higher VGPR rate as compared to Ibrutinib when assessed by an independent committee. And in that respect, the trial failed to meet its primary endpoint, with the VGPR rate being 28.4% in patients on Zanubrutinib, compared with 19.2% for Ibrutinib, and a p-value that was not significant at 0.0921. The investigator-assessed response was significantly higher for patients on Zanubrutinib, and with a further 5 months of follow-up, the VGPR rate for Zanubrutinib has matured to 30.4%, and there is now a positive p-value in favor of Zanubrutinib. Nevertheless, the study was set up to meet an IRC-defined time point, so it was considered a negative study for efficacy. Now, the most interesting aspect of this study, of course, is that this is the first study to compare head-to-head the toxicity profile of two BTK inhibitors. And true to Zanubrutinib being more specific and targeted, it actually was associated with a much better side effect profile, with reduced number of adverse events leading to death, adverse events leading to discontinuation or dose reduction or dose hold, and a very different side effect profile in terms of the typical BTK side effects, such as atrial fibrillation, bleeding, diarrhea, contusion, peripheral edema, all of which were lower in the Zanubrutinib arm. And is most notable for atrial fibrillation, where with prolonged follow-up, the AF rates were 18.4% for Ibrutinib compared to 3% for Zanubrutinib. So there's a 6-fold difference in AF rates between the two arms. The only disadvantage of Zanubrutinib in terms of side effects was an increased rate of severe neutropenia. But crucially, this did not translate to an increased risk of infection, either overall infection or severe infection. Essentially, we now have the VGPR rate at a single time point, which was negative for Zanubrutinib being superior. But we know that Waldenström's is a dynamic disease. So as patients go and stay on treatment for longer, you get a maturation of the VGPR rate. And I think an important aspect of this study will be the prolonged follow-up to see if there is a further differential in VGPR rate as patients stay on drug for long term. And of course, what really matters to patients are the progression-free survival. You know, a more potent drug that is more tolerable, would this result in a better progression-free survival in the long term with prolonged follow-up? I think that is the key question. At this point in time, both arms are doing really well. The other interesting aspect of this study is the quality of life analysis. For both arms, the quality of life improved because BTK inhibitors work really well in Waldenström's.